So this is a breast cancer awareness talk I was asked to give. Whenever these talks come up, you want to focus on sort of what you think is most important for everyone that's going to be part of your audience. So I've tried to do a general sort of informative talk, and if at any point you have questions, but we'll obviously have a Q&A at the end as well. So again, I'm Jessica Bensenhaver. I'm the director of the of the breast oncology program at Henry Ford Health System. And I'm honored to be here today talking with you guys. So what is breast cancer? Breast cancer is an uncontrolled growth of breast cells. It occurs as a result of mutations in the genes responsible for regulating the growth of breast cells. Normally, the cells in our bodies replace themselves throughout an orderly process. Healthy new cells take over as old ones die out. Over time, mutations can turn on certain genes and turn off others within a cell. The changed cell gains the ability to keep dividing without control or order. More cells are produced and a tumor is formed. And this is just sort of a diagram showing that process. Breast cancer usually begins in either the cells of the ducts, which are the passages that drain milk from the lobules to the nipple, or within the lobules, which are the milk-producing glands. Over time, the cancer cells invade the adjacent healthy tissue, then they can travel to the lymph nodes and then potentially on into the body. That's what we refer to as invasive breast cancer. Once it has the ability to spread, to go beyond the breast, it becomes invasive. The stage refers to how far it has gone beyond the original tumor. Normal breast cells become cancer because of mutations in their DNA, otherwise known as a mistake in the genetic material within the cell. Most DNA mutations, around 85 to 90%, are linked to breast cancer, are actually acquired. This means the change takes place in the breast cells during a person's life rather than having been inherited or born with them. Acquired DNA mutations take place over time and are only within the breast cancer cells. It's a result of the aging process and what we call wear and tear on the cells. Around 5 to 10% of the time, the DNA mutations are inherited or passed from your parents, meaning the mutations are in all of your cells when you're born. There are steps every person can take to help the body stay as healthy as possible that may have some impact on your risk of getting breast cancer, but this doesn't completely eliminate the risk, especially when you are born with a hereditary mutation. And I really like this slide because it kind of simplifies the explanation of acquired breast cancer versus inherited. So every cell has two genes. You have to have both genes damaged in order to get cancer. When you already are born with a mutation, one of those genes is already knocked out. So you're already one step ahead of the general population towards the development of breast cancer. So now a little bit about breast cancer statistics. It's the most common cancer in American women, except for skin cancer. It's the leading cause of cancer death in women other than lung cancer. In women under 45, breast cancer is most common in African American women. African American women are more likely to die from breast cancer. Interestingly enough, Asian, Hispanic, and Native American women are less likely to die from breast cancer. So the new cases and deaths in 2020, and these are obviously estimated, and this is from the American Cancer Society. The US lifetime risk for women who live to 80 is 1 in 8, so about 12%. Everyone hears that statistic, particularly during Breast Cancer Awareness Month. In regards to men, about 1 in 1,000 men. So in 2020, over 250,000 new cases of invasive breast cancer will be diagnosed in women, over 2,600 cases in men, almost 50,000 new cases of DCIS, which is pre-malignant breast cancer. And then there will be around 42,000 breast cancer deaths in both men and women in 2020. In regards to incidence, breast cancer incidence rates in the US began decreasing in the year 2000 after increasing for the previous 2 decades. They dropped by 7% from 2002 to 2003 alone. One theory is that this decrease was partially due to the reduced use of hormone replacement therapy by women after the results of a large study called the Women's Health Initiative that was published in 2002, which showed a clear link between hormone replacement therapy and breast cancer. From 2007 to 2016, invasive female breast cancer incidence increased slightly by 0.3% per year. When looking at mortality trends, this peaked in 1989 at 33.2 per 100,000 patients. In 2017, this decreased to 19.8 per 100,000. This translates to an estimated 375,000 fewer breast cancer deaths than would have been expected if the death rate had remained at its peak. Since 2007, breast cancer death rates have been steady in women younger than 50, but have continued to decrease in older women. From 2013 to 2017, the death rate decreased by 1.3% per year. These decreases are believed to be the result of finding breast cancer earlier through screening, increased awareness, as well as better treatments. As of January 2020, there are more than 3.5 million breast cancer survivors in the United States. This includes women still being treated and those who have completed breast cancer treatment. So a little bit about understanding risk. As I mentioned, the lifetime risk, the statistic that everyone hears is about 12.4% or 1 in 8 women. So it's accurate to say that 1 in 8 women who reach the age of 80 can expect to develop breast cancer. If you go by decade, though, the risk of getting breast cancer is lower than 12% for most women. You have to remember these numbers are averages for the whole population. So I really find this, this table interesting because, again, most women think, oh, it's 1 in 8, it's 1 in 8. But if you go by decade, it's actually less than that. So I really like when I'm doing these informative talks to sort of point this out so people can see, you know, where's my age, what's my likelihood of being diagnosed, and what's my likelihood of passing away with breast cancer. So a little bit about risk factors. Obviously, the strongest risk factors are age and being female. Your individual breast risk cancer may actually be higher or lower depending on several other factors: family history, reproductive history, lifestyle factors, and environmental factors. So it's really important to include all of these factors when you're trying to figure out exactly what any individual woman's actual lifetime risk of breast cancer is. So when we talk about risk factors, we divide them into controllable and non-controllable risk factors. So first, we're going to talk about controllable risk factors. Weight is number 1. Being overweight is associated with an increased risk of breast cancer, especially for women after menopause. There's somewhere between a 20 to 40% increased risk. Fatty tissue is the body's main source of estrogen after menopause, when the ovaries stop making estrogen. Having more fatty tissue means that you have higher estrogen levels, which can increase your breast cancer risk. Diet is something too that has been extensively looked at, and there was the Women's Health Initiative trial suggested that very low-fat diets can reduce the risk of breast cancer. We have a dietitian program that we send our patients to if they are interested, and this is just a little bit of the information that they give to those patients. Again, maintaining a healthy BMI, eating plenty of fruits and vegetables, limit saturated fats, limit total fats, eat foods high in omega-3 fatty acids, and avoid trans fats, processed meats, and charred or smoked foods. In general, if you look at this, it's basically all of the generalized healthy recommendations for all people. When looking at exercise, alcohol, and smoking, there's evidence growing regularly that shows that exercise can actually reduce breast cancer risk. The American Cancer Society recommends engaging in 45 to 60 minutes of physical exercise, or at least 5, if not more, days a week. Alcohol consumption is another hot topic. Breast cancer risk increases with the amount of alcohol a woman drinks. Alcohol can limit your liver's availability to control blood levels of the hormone estrogen, which obviously we talked about increases your risk. 1 drink per day can increase your risk around 5%. 2 to 3 drinks per day, around 20% increased risk. Smoking is also associated with a small increase in breast cancer risk. So a little bit more about estrogen. So how does this work? Estrogen stimulates breast cell growth. Because this female hormone estrogen stimulates the breast cell growth, exposure to estrogen over long periods of time without any breaks can increase the risk of breast cancer. Some of the risk factors that we can control in regards to estrogen exposure are hormone replacement therapy. It has been shown that for 10 consecutive years of use can increase your breast cancer risk. Being overweight, again, that high BMI leads to higher peripheral fat, higher peripheral production of estrogen, and obviously an increased risk of breast cancer. And again, drinking alcohol regularly, because it increases that estrogen exposure. Oral contraceptives I'm asked about all the time. Oral contraceptive use appears to slightly increase a woman's risk for breast cancer while they are taking it, but it's typically only for a limited period of time. This decreases over a 10-year period once you stop. So at a 10-year mark after stopping oral contraceptives, there appears to be no increased risk of breast cancer. So now we're going to talk a little bit about uncontrollable risk factors. The most significant, number 1, gender, and number 2, age. Being female is the biggest risk factor for developing breast cancer, but risk increases with age. So by age 30, a woman's risk is 0.5%. By 70, this risk is 4%. Family history of breast cancer. If you have a first-degree relative who has had breast cancer, or you have multiple relatives affected by breast or ovarian cancer, especially before they turn 50, you could be at higher risk. Also, having a personal history of breast cancer leads to an increased risk of developing a second brand new breast cancer in either breast. In regards to race and religion, race and radiation, historically, white women were slightly more likely to develop breast cancer than African American women. However, this incidence is now the same. Interestingly enough, though, the mortality rate is still significantly higher for African American women. In regards to Asian, Hispanic, and Native American women, they have a lower risk of developing and dying from breast cancer. In regards to radiation, radiation to the chest was something common about 20 years ago for lymphoma. There were a couple other reasons that patients would get this, but by far that was the most common. And what we discovered was that the increased risk seems to be highest if the radiation was given while the breasts were still developing, so during the teen years. So any patient that has had chest wall radiation, all of those undergo high-risk surveillance. Breast cellular changes. Unusual changes in the breast cells found during a breast biopsy. So these changes can be a risk factor for developing breast cancer. They include overgrowth of the cells, something we call hyperplasia, as well as abnormal or atypical appearance of cells. Again, estrogen exposure that you can't control, early menstruation, so before 12, late menopause after 55, and exposure to estrogens in the environment, such as pesticides, which produce estrogen-like substances when broken down by the body. Pregnancy and breastfeeding. Pregnancy and breastfeeding reduce the overall number of menstrual cycles in a woman's life. This appears to reduce future breast cancer risk. Women who have never had a full-term pregnancy or had their first full-term pregnancy after 30 have an increased risk of breast cancer. For women who do have children, breastfeeding may slightly lower their breast cancer risk, especially if they breastfeed for at least 1 year. For many women, though, breastfeeding for this long is neither possible nor practical. So moving on from risk to early detection. All I can say is please screen, screen, screen. For average risk women, we recommend that you start at least the discussion about annual mammography with your physician around the age of 40. Early diagnosis, we know, reduces the risk of dying from breast cancer, and it increases treatment options. We have to remember, though, that mammogram isn't perfect. It can miss some cancers, what we call false negatives, or it can appear abnormal in the absence of cancer. That's what we call false positive. Somewhere around 12% of women who are screened have an abnormal mammogram, but only 5% of those actually have a cancer. So there is some anxiety associated with that abnormal screen, which ultimately leads to nothing. However, I always like to point out again, it identifies those 5% that have the cancer that otherwise wouldn't know. In regards to MRI, this is something that we consider a high-risk screening tool. It is recommended to accompany mammography for women who are identified as high risk. So what is high risk? Anyone that has a personal or a family history of breast cancer, anyone who has been identified through risk assessment as having a lifetime risk greater than 20%, or someone with a known mutation that's associated with the risk of breast cancer. Any of those women have the option of MRI in addition to mammogram. And if we know, you can start the MRI as early as 25. Mammogram we don't recommend before 30 because of breast density. The breasts are so dense prior to that mammogram really doesn't show us much. And last year, the American Society of Breast Surgeons came out with a new recommendation that all women should have risk assessment performed at the age of 25 years old. So what does that mean? A risk assessment is when a model that includes personal, family, hormonal, breast cancer risk factors to come up with an actual number that defines your lifetime risk of breast cancer. Any physician can do that. You may have heard of something called the Gale risk model. That used to be one that was very popular. It's been replaced these days, but it's one that women frequently can identify with. But if you are found to have a greater than 20% lifetime risk of breast cancer, remember, average is 12. So if you're greater than 20, you qualify for high-risk screening with MRI. So a little bit about staging. The purpose of staging is to determine how determined by the cancer's characteristics. We want to know things like how large is the cancer, has it gone to the lymph nodes, has it gone beyond the lymph nodes, and whether or not it has hormone receptors. The stage of the cancer helps us to figure out the prognosis, to decide on the breast treatment options, and to determine if certain clinical trials may be a good option. Breast cancer scale stage goes from 0, which is what we consider pre-malignant, through stage 4, which means it's gone beyond the breast and lymph nodes to the rest of the body. And although simple, I don't know if you guys can see my cursor, I like how this sort of shows the progression of breast cancer. So stage 1 is typically a very small breast cancer limited to the breast. Stage 2, the tumor is a little bit bigger. Stage 3, it has spread, it's a little bit bigger and has spread to the lymph nodes. And then stage 4 is it's gone beyond the lymph nodes throughout the body. And in breast cancer, the most common places are the lung, the liver, the bones, and the brain. So mortality by stage, we used to go stage specific. Today we use more localized, regional, or distance. And I think this is a great table to show to patients so they can better understand exactly what the expectations are. This day and age, around 60% of women that are diagnosed are actually diagnosed in stage 1, which is what we consider local disease. It's very treatable, it's treatment for cure. The prognosis is excellent, it just needs to be treated. As the stage goes up, showing patients this helps them to understand exactly where they fall. So this is something that I really like to utilize with my patients so they can kind of get an idea of where they are and what to expect. And also it helps them to understand why we are sometimes recommending the treatments we're recommending. All right, breast cancer management. So this is a busy slide, but this is the picture that I draw out for my patients every time I see a new breast cancer patient. When we talk about breast cancer treatments, we have both local regional treatments and systemic treatments, and they typically fall in the course described in this slide, starting with surgery, followed by chemotherapy, and sometimes we flip-flop that, then radiation, and then endocrine therapy. One thing I like to always point out is that breast cancer is not one disease. It falls in a spectrum of very low aggressive, early stage, not very threatening breast cancers, all the way up to incredibly aggressive, fast-growing, what we call interval development breast cancers that can spread very quickly, and everywhere in between. Some patients require all these treatments, some require just one or two, some just one. It's completely dependent not only on your tumor, your stage, but the biology of the tumor, how aggressive it is, and what exactly we need to maximize your outcome. So just a little bit about surgery options. In regards to the breast, we have the option of mastectomy with or without reconstruction. And then breast conserving therapy, otherwise known as lumpectomy. But I always like to make sure that everyone understands breast conserving therapy by definition means not only the lumpectomy where you remove the tumor with a shell of normal breast tissue all the way around it, that's shown in the lower picture in the middle, but it also requires radiation. Radiation is what makes the lumpectomy operation equivalent to mastectomy in regards to survival. Anytime we do a cancer operation, we also have to check the lymph nodes to see if the cells have gone from the breast to the lymph nodes. Again, that's important not only for staging, but it also helps dictate what treatments we recommend. And that usually starts before surgery with an ultrasound plus or minus a biopsy. At the time of surgery, we do a sentinel lymph node biopsy. Sentinel node, by definition, is the first node that drains the breast. So if cells have gone from the breast to the lymph nodes, they would be first in those sentinel nodes. So those are the ones we check first. If it appears that the cancer cells have gone through multiple nodes, then sometimes we have to remove all of them. That's what we call an axillary lymph node dissection. In regards to systemic chemotherapy, that's frequently the second step. Again, as I mentioned earlier, sometimes it's the first step, but frequently the second. The reasons we talk about chemo: if patients have cancer in their lymph nodes, we talk about chemo. If they have an aggressive biology, either a triple negative or a HER2 positive, those patients get chemotherapy regardless of their lymph node status. Also, too, something called genomic index score. If your tumor is node negative and not triple negative or HER2 positive, there is a test we can do on the tumor that gives us a recurrence score and tells us whether or not you're going to benefit from chemo. And then again, as I mentioned earlier, sometimes we do chemotherapy first. That's what we call neoadjuvant chemotherapy. And you oftentimes will see patients that will say, well, yeah, I did chemo first and then surgery. This is helpful for us because it helps to downstage the tumor. Frequently, if we know a tumor is going to respond to chemo, we give chemo first because it makes the tumor smaller, and it also sometimes completely eradicates cancer cells in the lymph nodes if they're there. Altogether, the reason this is beneficial is because it leads to a less aggressive operation. Radiation is typically step 3. It's either to the breast or the chest wall. Again, as I mentioned earlier, we always talk about radiation after the lumpectomy operation or the breast conserving therapy operation. Post-mastectomy radiation, we recommend if the tumor is greater than 5 centimeters. And then we typically recommend radiation if there is greater than or equal to 4 nodes positive. Lastly, we talk about endocrine therapy or anti-hormone therapy. This is for tumors that are fed by estrogen and or progesterone. There's 2 classes of these medications. One is the tamoxifen, which I'm sure you've heard about, and the other one is called aromatase inhibitors. Aromatase inhibitors are only for postmenopausal women because it actually blocks the conversion of androgens to estrogen. So aromatase inhibitors won't work if your ovaries are still functioning. So a little bit about survival. Overall 5-year survival rate is around 91%. Overall tenure, and this is all comers, overall 10 years around 84%. I think I mentioned this earlier, around 62% of cases are diagnosed as local or early stage. This 5-year survival for that is 99%. This is why it's so important that mammograms are done, that screening is done, and that we find breast cancer early, because that's when we have the most opportunity to treat it and have better outcomes. And then I think just something worth mentioning, survival rates are about 9% lower for Black women in comparison to white women. Obviously, this is a disparity that is unacceptable, and reducing these disparities in outcomes for Black women is a focus for many national cancer organizations and something that we focus on a lot at Henry Ford. because we do have such a significant African American population in the Detroit metropolitan area, we are seeing a lot of these more younger, more aggressive triple negative tumors. A lot of the research that we're doing is focusing on that group and trying to figure out a way to better treat these patients. And that's about it. I always end with this slide because of the black stripe. The black stripe on the pink ribbon has been added by many breast cancer survivors to remember those who have died from breast cancer, and also as a reminder of the 40,000 women and men expected to be diagnosed with metastatic disease each year. And that is it. How am I doing on time? That's like almost exactly 30 minutes. Can you guys hear me?
Yes, can you hear me?
Yes, I can now.
Okay, good. I was hoping people would have questions and would like to, you know, spend the next maybe 20, 25 minutes asking you questions.
Absolutely.
So if you have a question, please just, I guess you can raise your hand. There's a raise your hand feature.
Sure. I think Marion has a question.
Okay, let me see if I can unmute her. Yep, she has one.
Yeah, she's still on mute.
Yeah, let me see.
Oh, here, I think I can unmute her.
Well, go ahead.
There, okay.
There you go.
You had that graph with a lot of percentages, and there were titles across the top that I didn't understand.
Okay, so the titles across the top were local, regional, and distant. So what that's talking about is the stage. And I think it makes it a little bit easier for patients to understand than to say, you know, stage 1, stage 2A, 2B, stage 3A, 3B. So whether or not it's in the breast and the lymph nodes or beyond. So that's what that was referring to.
Got it.
Any other questions?
I have a question.
Yes.
Can you hear me?
Yes.
I'm 38 years old, and a few weeks ago I asked my doctor if I could possibly get a mammogram, and she said that since I don't have a family history or anything, there's no need for me to get one. But what if you want to make sure that everything's okay? Because you mentioned something about breast
risk assessment. Yes, absolutely. I'm so glad you're bringing this up. So even without a family history, there are many things that can be pulled into your personal story that could potentially increase your risk. For example, how old were you when you had your period? Do you have children? If you do, how old were you when you had your children? Did you breastfeed? Your height, your weight, and there are risk assessment models. So the one that I use the most common is called the Chire Cruise. It's actually free online. If you Google IBIS risk assessment, it pops up. Now, it can be a little tricky. Some of the questions, obviously, it's made for healthcare providers, but most patients, I feel like, can get through and answer the question. So I think the very first question is your age. Again, when you had your period, do you have children, your height, your weight? Have you had a mammogram before? Have you had an abnormal mammogram? And as well as your personal and family history. And it will actually give you a number. If that number is higher than 20%, then you would qualify for mammogram and the MRI actually now. So I would recommend one or two things. I don't know if you went to your PCP or gynecologist. Oftentimes the gynecologists are either a little bit more familiar, or you can always be referred to a breast surgeon. I'm happy to see you. Any of my colleagues would be, in order to figure out, A, are you high risk, and B, if you are, what do we need to do to minimize your risk?
Okay, Wes, let me.
Yep.
Hi. I have two questions.
Yes.
Oh, okay. My first question is, I have a friend who's like 15 years out from when she was first diagnosed with breast cancer, and she's doing everything that, you know, she should do for follow-up and whatnot. But my question is, the further you get out from your initial diagnosis, Is that a good thing? Is there a risk that it may
Yeah.
out of the blue come back? And then my second question is, as it relates to COVID and what you're seeing, if anything, with your patients and treatment and all that good stuff.
That's a great question.
And are you doing a lot of telehealth kinds of
Yeah,
things?
yeah.
Thank you.
So in regards to your first question and distance from diagnosis, so yeah, so we quote patients about 0.8% per year. If you look at the actual recurrence rates, it's highest in the first 5 years. In those 5 years, it's highest between years 1 and 3. So once you hit year 5, we take a kind of a deep sigh of relief. That said, it's still important for those patients to continue screening, even more important, because even though their risk is coming down, it's still higher than the general population. So she still needs to continue doing her annual screening, her annual breast exams, just to make sure that she does continue to do everything to minimize her risk, because inherently, although it's coming down, she's still higher than the general population. And as for COVID, hasn't the world changed? So the one thing that, from a breast cancer treatment perspective, that we were able to accommodate is at least initiating treatment, because the operating room was shut down for a couple of weeks. So we did have to delay some surgeries. However, it is atypical that we can't treat it somehow. So for any patient that was diagnosed that had either a triple negative or HER2 positive or a high oncotype score, something that indicated that we knew no matter what they were going to need chemo, then we would just start them on chemo. If they were ER, PR, so estrogen and progesterone positive, but we didn't know they would need chemo, we put them on anti-hormone therapy. So we were able to start their systemic treatment in order to bridge us to when we could actually operate on them. I think one of the biggest things that I've seen in regards to breast health, though, is we had to delay a significant number of mammograms, screening mammograms. And then once we got the all clear, once we had instituted the safety measures to bring patients back in for screening, there was definitely in the beginning a significant number of patients that sort of felt like, I'll just wait till next year. And I tried very hard to make sure that these patients understood that please don't do that, because we need, if you're supposed to be getting annual mammograms, there's a reason for that, please come in. And we've actually been able to see that those patients have come in. We have very few that have done that ultimate delay for a year, albeit they have all been delayed by a couple of months. But definitely, please, if there's anything I can, any public service announcement I can put out there, please continue to get your screens.
I have a question.
Sure.
Do you know of, well, a couple of things have happened to me. I'm very diligent about going to get my mammogram, because I was one of those people who started menstruating at 10.
Oh, geez.
And I never had any children. So that was lovely. But my question is, I found out from my GYN last year, she said that when you go and start Medicare, they only allow screening with a mammogram every other year. Do you know if that's true, or?
So every insurance is different, but again, this is one of those reasons that I find it really important for either a PCP or the gynecologist, or again, if you have any concern, come see a breast surgeon, to run that risk assessment model. You'd be surprised. As you get older, yeah, your lifetime risk is going to go down. But if you, again, had that early period, late menopause, no children, that does put you in a different category. Being African American puts you in a different category.
Exactly.
So I would definitely recommend running risk assessment, because you may be surprised where you fall on a lifetime risk scale. And if if that is accurate and you fall above 20%, you not only would qualify for annual mammogram, you'd qualify for MRIs too. They're a lot more sensitive, but we do them on purpose for patients who are high risk.
How about places to go for free mammograms? Do you have any recommendations for that, or are there any?
Yeah, so the American Cancer Society has a lot of connections that will, and programs that will pay for mammograms if you need them. I know in the Downriver area, there's a Yes Ma'am program that basically pays for all women's health needs. And that's been super helpful for me, because I work not only in the Detroit area, but also at Downriver. if you have a concern, if insurance is an issue and you need a mammogram, just reach out. The American Cancer Society, like I said, has a lot of great programs. We have a Game on Cancer program at Henry Ford that's also very helpful. So it's pretty rare that we can't figure out some way, somehow to get patients screened.
That's good to know. Okay. Thank you.
Okay. I have a question.
Yes.
Yeah, can you hear me?
Yes.
Okay. All the information you gave was really good. But do you have something that you say to women who are in their 50s, not yet 60, who live their lifestyle, with all the things that you're saying not to do, the smoking, the drinking, the eating the fatty foods? Is there something that you can say to them to encourage them to do?
It's interesting because with my job as a surgical breast oncologist, outside of women who are identified as high risk, I unfortunately don't frequently see patients until they're already diagnosed. Oftentimes at that point, they ask, what can I do to make sure this doesn't happen again? And obviously at that point, they're facing this cancer diagnosis, so their perspective is very different. You'd be amazed at the number of women that will stop smoking at a cancer diagnosis. And with breast cancer too, to me, I told them frequently, I was like, look, this is a really hard time to try to take care of an addiction on top of dealing with this diagnosis. And it amazes me, and we have cancer cessation programs we send them to, but it amazes me the number of women that can successfully quit that have been smoking for decades. So that said, if I do have the opportunity to talk to women who aren't diagnosed, who are high risk, or who I'm seeing for another reason, I do make sure that they know we do talk to them about lifestyle modifications that can help decrease their risk. Now, then I also have that conundrum where I have these patients that have been doing everything they're supposed to be doing and they still get diagnosed with breast cancer. In those situations, I like to make it very clear to them, everything you are doing has brought your risk down to a point where you're getting this now maybe at 60. Had you not been doing those behaviors and maintaining a healthy lifestyle, this could have happened 10 years ago. There's no way to know, but it's not that what you were doing was in vain. It was helping. And now, we're here where we are, but this could have happened a long time ago and been a much worse scenario. So I try to put it in perspective and make sure patients, if they're faced with it, they don't feel like everything they've done is in vain, because it's definitely not.
Okay. All right. Thank you.
Yes, Marion.
I looked at the IBIS risk assessment.
Oh, good.
It was pretty easy. It was mostly in English, but then they asked something about hyperplasia.
Yes. So what is that? What that is asking is if you've had a breast biopsy that showed hyperplasia. So a needle biopsy where they've, where after a mammogram, they brought you back and said, there's an abnormal finding, we need to take a tissue sample. That's what that's requested.
What is the hyperplasia that it showed?
So what the concerning finding is if it's atypical hyperplasia, because that's a high risk finding. And that's what that question is asking. And I will say this, a lot of times I'll tell patients, if you're going to do this, you need to review it with a doctor, but do it first. If you want to do it by yourself, if you don't know the answer, certainly just, you can leave that part blank and see where you fall. But if you're concerned, definitely do it with your doctor, particularly if there's something like that you don't know how to answer.
And would you slow go, there was a question about free mammograms, and I could put it on my Facebook page or mayor's message or something at Henry Ford and something at MAM.
Oh, so in Downriver, there's a Yes Ma'am program, and I can actually send that to you if you I have my email is through Karen. So just I can send you all those programs if you want to.
Okay.
Yep.
And I'll put them out there, and
sure.
And plus the information about Black women at risk. We need to get that out. And I was supposed to go in for a mammogram, I think in January, and COVID hit, and I was those ones that didn't that put it off. And after hearing you, I'm going to make the appointment.
Good. Excellent.
Put that in the message to everyone else.
Yes, please.
I found this very, very valuable. My mother died of breast cancer.
Oh, even more important. having a first degree family member, even outside of a genetic mutation, increases your risk slightly. So definitely, please go get your screen.
Thank you.
So as a retired Henry Ford ER social worker, I wanted to give the phone number to the American Cancer Society in Southfield, which is 248-663-3400.
Thank you.
And you would ask the American Cancer Society for any program for free mammogram?
Yeah,
Right.
and I can send you again the programs we have that people can call and ask about.
Okay.
I'll send them to Karen. Is that fair?
Yes, that's fine.
Okay.
And I'll send them out. Can I ask you a personal question about your journey?
Sure.
How did you decide to be an oncologist and breast cancer?
So that's a great question. So I was born and raised in very rural West Virginia. The town that I grew up in had about 1,200 people in it. And I always knew, for whatever reason, when I was a little kid, that I always wanted to be a doctor and that I wanted to be a surgeon. When I was 6 years old, my grandmother was diagnosed with lung cancer and passed away within a year. When I was 8 years old, our nanny was diagnosed with breast cancer and also passed away within about 3 months. She was metastatic when she finally, told someone what was going on. So very early in life, I was exposed to not only cancer, but cancer death. And then when I was a resident, a surgical resident, it was very clear to me the disparities in socioeconomic scenarios as well as race disparities. And that was something that I found very intriguing. So as a surgery resident, I decided to do a fellowship in breast oncology. At the time, I was not convinced I was going to do just breast. I thought I was going to do a hybrid practice, but within 6 months, I ended up doing just breast. We were that busy. I was at U of M for 5 years before I came to Henry Ford. And just the number of patients coming in, the amount of work that was clear that needed to be done was just overwhelming. But I can say too, people frequently ask, why do you do this? Why do you deal with cancer? We have a lot of good outcomes. No matter what you do, there's always going to be sad stories or difficult stories, difficult patient scenarios that you have to deal with. But I can tell you that for all of the heartache, there's a lot of good. And being able to help be a part of curing somebody of their breast cancer is something I will never underestimate.
Interesting. Okay. We didn't talk much about it, but what about breast cancer involving men?
Yeah, so it does happen. It's about 1 in 1,000 men, so definitely less. So if you think of 1 in 1,000 compared to 1 in 8 women, it's definitely less common. That said, I usually see about 3 or 4 a year. Traditionally, because we don't screen men, they are frequently diagnosed at a later stage, usually stage 2, 3, sometimes 4, as opposed to women who are typically diagnosed. Most women are diagnosed in stage 1 this day and age. And again, it's because we don't screen them, and it's typically, they have, after they've developed a palpable mass, and of course they're like, well, men are usually like, this is nothing. That said, the treatments are pretty much identical in regards to surgery, chemotherapy, radiation, and anti-hormone therapy. So it does happen. Also, too, there's genetic predispositions that put men at a higher risk. So anytime I have a man that is diagnosed with breast cancer, we always send them for genetic evaluation. Also, too, one of the big questions in risk assessment and for just determining your family history is whether or not you have a male family member with breast cancer. Definitely significant. Yeah.
Yeah. So are you doing any tracking of that? Because I'm thinking if you see 3 or 4 a year, is it possible that you can track those families and see what happens?
Oh yeah, absolutely. And now remember, that's just me. That's not my partners. So in total, I haven't looked at our Henry Ford numbers recently in regards to men. But you know, it's definitely more than my cohort of patients. But yeah, we can track them, and frequently we do find mutations, and we oftentimes end up doing high-risk screening on their family members.
Yeah, I could see that. That's interesting. That would be real interesting.
Yep.
Do you get a lot of repeat patients? Unfortunately, like once you see one and you do surgery, do they unfortunately make return visits for further surgery, whether it's new or old?
Yeah. So, you know, the longer you do this, the more recurrences you're going to see. And again, we tell patients their risk, it's rare. It really is rare, but it is there, and it is more than the general population. But it's about 0.8% per year that is decreased by things like hormone therapy or anti-hormone therapy, endocrine therapy. But yeah, I do, I've been doing just breast since 2011. So I am starting, around 10 years out, I'm starting to see a lot more recurrences. I guess the sort of defining factor when you see a recurrence is it a local regional recurrence? So is it just in the breast and the lymph nodes still, or has it come back in the body? Because the options for those two scenarios are very different. That said, there are new treatments, targeted therapies, and options coming out every day. And even in my what I call breast cancer lifetime, so my career, the treatment options have just exponentially increased for all different types of breast cancer. So I try sometimes to be very realistic with patients when they either present or come back with a metastatic or systemic breast cancer. But there are some scenarios where, if adequately treated, you can live with it for a very, very, very long time. I know there are commercials now on all the time talking about metastatic breast cancer and treatments for it that are making women live for years and years and years. And it's accurate. So, again, every case is different. Every tumor biology is different. So you have to really know all of the details when you talk to these patients, but it's not atypical this day and age that I can, look at a patient and say, yeah, it's in your bones, but we can still treat it, and you can live with breast cancer as a disease.
Are there breast surgeons who specialize in a particular type of breast surgery? Like there might be some kind of breast surgery that you don't feel comfortable or qualified doing, or do all breast cancer surgeons do all types of breast surgeries?
So that's a great question. I think one of the things that people in general get very confused about is a breast surgeon versus a plastic surgeon. So I am not a plastic reconstructive surgeon. I am a breast cancer surgeon. So breast cancer surgeons are taught how to do the cancer operation. So that's what I specialize in. I can do some degree of oncoplastics, but when it comes to major breast reconstruction, that's done by a reconstructive plastic surgeon. So we frequently work together. So often, if I have a patient that comes in that say needs a mastectomy based off of either having a history of radiation or extensive disease, and I'll tell them, well, I need you to see the plastic surgeon so you can talk about your reconstructive options. They're like, oh wait, I thought that was you. I'm like, no, we're two different, but we're all part of the same team, but we do two different things. But oftentimes work together. At least 1 or 2 times a week, I'm doing a breast cancer case with a plastic surgeon.
Do they do this procedures at the same time, or is there a lapse time for person to recover?
Both, and it depends on the case. If we can, the majority of the time we will do immediate reconstruction, meaning I remove the breast, leave a skin envelope, and then the plastic surgeon comes behind me and does the reconstruction that they and the patient have decided upon, be it an implant-based reconstruction or potentially sometimes the same tissue from the patient from another part of their body. But yeah, sorry. So we definitely work together. There are definitely multiple options. It's amazing what we can do this day and age, I will say that. Yeah. Particularly with plastic surgeons. I mean, you can remove an entire breast through about a 3-centimeter incision, and then the plastic surgeon can come and do a reconstruction and a lift. And oftentimes, and there's no silver lining to a breast cancer diagnosis. I always say this to the patients, but I will say, you know what? if this is something you've been interested in, we can make you oftentimes look much better and be more confident than prior to.
Okay, that's interesting. That is. I for years worked at the Carmanos Cancer Institute, so I have had some experience with this. So yeah, and that was unique. We did clinical trials. We provided clinical trials for people.
Oh, very cool. Yeah, it's again, the treatment options are changing exponentially every year. It used to be, like you had mentioned, that you could get reconstruction, but it was delayed. It was at least 6 months after radiation.
Wow.
And there was some degree of time you had to go without a breast. It's pretty rare these days that that happens. There are still some situations where we don't have a choice, and it is better for the patient to do a delayed reconstruction. But I mean, I can definitely tell you in my career's time, we've gone from being very selective about offering immediate reconstruction to now we're selective about those we don't offer it to.
Good. Are there any more questions? I thank you for doing this. This has been a really interesting program. I really appreciate your providing us with this information.
Absolutely.